Welcome to the Virtual Shift, a show looking at the seismic changes happening in healthcare with virtual care at the epicenter. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and the future. Hello, and thanks for tuning in today. I'm your host, Tom Foley. You can learn more about this show by visiting the program on healthcarenowradio.com, and be sure to follow me on LinkedIn, Twitter at FoleyTom, and the hashtag The Virtual Shift. Today we have a great guest on, Dr. Herbert Bravo. He is the host of the Pediatric Lounge. Dr. Bravo, welcome to the program.
Hi. Thanks for having me today.
Awesome. So, Dr. Bravo, tell us a little bit about yourself and the Pediatric Lounge.
I'm a general pediatrician, and the Pediatric Lounge started as a project to have conversations that highlight very successful pediatricians in today's environment, mostly independent pediatricians who are delivering great quality and yet are able to make money.
Tell me a little bit about what's different in those practices. You know, at the end of the day, healthcare, everybody has to be viable, right? The provider has to be viable, the practice has to be viable, and the patient has to be all engaging in order to really achieve the mantras of this reimagined delivery of care model called value-based care. What's different in those models with a pediatrician that is successful?
So what I can see from these leaders in the industry, one, they value relationships, the relationship between themselves and the patient, their relationship between themselves and other community physicians, their relationship between themselves and vendors. They have a strong mission and passion for what they're doing. They're willing to learn from others to provide not efficient but effective care, and they're willing to change.
Yeah, that's a big word right there. Change. It's not delivery of care is not the model that it used to be. The consumer has changed. The desires of the consumer have changed. And at the end of the day, this reimagined delivery of care model has just as much to do with change in meeting the consumer where they're at. And I did call them a consumer versus a patient, where they're at versus get in here into this brick and mortar facility that I have, and this is the way I'm going to treat you, type of thing. Thoughts on that?
Yes, I think there's been a lot of change in society in the last 20 years. The iPhone's been around for, 11, 12 years? This wasn't possible. Zoom meetings weren't possible 3-4 years ago. So there's been a lot of change in our society as a whole. And medicine is very slow to change, and we're just kind of catching up to using all these tools.
Just catching up to using all these tools. You know, in our pre-conversation, we talked about regulatory mandates and doctors having to adopt technology, whether it be EHRs, patient portal, things of that nature. Do you think that there's a better approach to delivering or achieving the desired outcomes of a reimagined delivery of care system outside of mandating technology adoption?
I think the laws are obsolete, and they were done with great intentions, but the unknown unknowns have caused great harm.
Yeah.
So if you look at HIPAA, it's kind of ridiculous that I can have a conversation with a patient on the phone. I don't need any special app. I just use a normal phone, my cell phone, voice over IP in the office, a regular oral line, and that's not regulated by HIPAA, but anybody can tap into that conversation. But I can't send you a text as a patient unless I have a HIPAA compliant text messaging app so that I comply with HIPAA. Does that make any sense?
No. And to some degree, the idea of, what the consumer is willing to accept as a risk, if you will, right? Because they're part of the equation. Better outcomes isn't achieved by the doctor telling you what you have to do, with all due respect. Better outcomes is achieved when the patient does what you tell them they need to do, right? There's a huge difference. Yeah, execution. It's that behavioral change. It's that word again comes up, change, right? So I'm a believer that, and I'm not just saying this because you're a provider, but I've said long ago and many times, the doctor is the smartest one in the room. However, they can't change outcomes. The only one that can change an outcome is a surgeon, because they're doing something physically, right? A doctor
Okay.
I say this in the context of a doctor has to influence their patient to change,
Most
right?
of what we do is influencing. However, the untold story is that pediatricians in America have changed healthcare through vaccinations, but we don't get reimbursed for that.
Can you repeat that
So,
again?
so pediatricians in America have changed healthcare for the better by vaccinating the kids. So, for example, I could probably bet you $100 that you have never seen a patient with polio.
I've seen my first basketball coach had polio, but that was back in the 70s, but not,
Not
I
up to you.
haven't seen it developed exactly.
Okay. Today, pediatricians all over the country in small offices are vaccinating thousands, if not hundreds of thousands of kids against cervical cancer, oral cancer, and neck cancer. What is that dollar attributable to? The OB-GYN, because he or she is not going to have to be doing pap smears every year anymore, but every 3. They're not going to have to do surgery and chemotherapy to remove the cervix and the uterus in any of these women that are vaccinated. But that's not attributable to the pediatrician because it doesn't happen this quarter. It happens in 10, 20 years. So we can't change the course of illness early on without surgery.
Interesting point. So isn't that in some context value-based care?
It's tremendous value, right?
Right.
Yet the payers are not interested because they run in quarter to quarter. That's what the executive team gets bonuses on. That's what their stock is driven by. So what happens to this patient 20 years from now is not important to them. They don't care whether
Yeah.
I keep the kid out of the urgent care, the emergency room, because that's cost savings this quarter. That's not
So
value care.
I'm writing a blog actually as we speak, right? And the blog
Okay.
is what's value? And the point there being is, we talk about value-based care in the context of reducing costs, increasing outcomes, the 4 mantras of value-based care. But at the end of the day, if I were adoption of, maybe not so true in the pediatric space, but if I was a general practitioner or a specialist treating patients with chronic conditions, I could provide remote patient monitoring. I can provide remote therapeutic monitoring. I can provide chronic care management. None of those are value-based care oriented programs. They could be, but in the context of CMS CPT codes in the classic model, they're not. And the point there being is I can ultimately reduce the cost of care, increase the overall outcomes of care without taking on any risk. But risk seems to be an important component as to whether or not you're providing value. And therefore, I think the model might be wrong. What are your thoughts?
I think the model is wrong. It's absolutely wrong. But you're correct that the biggest cost savings occur at the end of the curve. So if you look at people over 55, most of us have more than one chronic condition already. And the average person, as you get older, spends $11,000 to $12,000 a year in healthcare, while a child spends $2,000. So if I can just doing the math, if I can save 20% of 11,000, that's about $2,000 per person. I can't do that on the other end when it's only $2,000. It's such a small amount.
Well, to your point, in the context of, there's a couple bridges we need to cross here. Is because ultimate value, is about walking across different islands, if you will, to get to the end. To your point, most of the money spent today is spent on the 65 and over. As a matter of fact, it's roughly 80% of the healthcare dollar is spent in that category. That said, we can continue to try to reduce the spend in that category, but yet you always have more people coming in. So you're only going to go so far as to your ability to bend that curve. If we focus on wellness, that's where you come into play. Pediatricians, they have the attention of the parents and the child themselves on how do we manifest a different mindset of wellness so that we don't develop those chronic conditions as we get older. Thoughts on that?
So we're all going to get sick, so we're all going to have to spend some money on healthcare at some point. That's, you can't prevent every disease. As you get older, I think we need to change a little bit about the thinking is not preventing, but early diagnosis and interventions. So if you become obese, I may not be able to prevent through a vaccine or a medicine everybody in America from being obese, but I might be able to keep you from getting diabetes type 2 or heart disease. And that's when all these monitoring things are very helpful. Because if I'm seeing that you're gaining 10 pounds a week, that scale's not lying. And you've got
Yeah, well,
AI tied up to that, and it's telling me, hey, this patient of yours gained 10 pounds last week and this week. It's like, let's come in here, let's see what's going on. So I can drive the change.
well, isn't that you kind of nailed it in the context of, you mentioned obesity. It's an epidemic in and of itself, and it's starting in the younger ages, right? And it manifests
Yes.
itself in the older age, right? So how do we
Yes.
change the education and awareness about, hey, not that there weren't obese kids when I grew up, but we were always playing basketball, baseball, wrestling. We were always involved, right? We weren't sitting in front of the TV for the most part, as you read a lot about kids playing video games, right? So there's a huge difference in how kids are growing up. Not that they're all in front of video games, by the way, but the point there being is there needs to be a lot more sensitivity to diet and exercise as kids are younger, so that, again, things don't manifest itself. Thoughts?
So my thoughts is that the way the U.S. society values care for children is regrettable. They pay the least for the care that the youngest get, which are our future, not only intellectually but financially and morally. I'm not. It makes money, but I'm not a believer that seeing someone at 12 years of age once for their physical, and then again at 13 once, and at 14 once, allows me to have any influence on their behavior. So as long as we're still paying for periodic care, or the value contracts are looking at how many of my 12-year-olds got a physical this year, which is a process measure, it's not changing anything, especially in the Medicaid environment, where in Virginia you can get paid $55 for seeing a Medicaid patient. So what happens? 50% of pediatricians in Virginia can't afford to see Medicaid. Is that value? Is that good for society? No. We need to put our money where our mouth is. If children are important, if early prevention and relationships are important, then we need to pay a lot of money for that care and less for the hospital care. How do we do that? Well, for example, direct to consumer primary care, DPC, where it's a fixed $50 a month per kid. Whether we do it on the phone, you come into the office, we do it on Zoom, you pay your $50. There's no co-pays, no barriers to access. And I get paid for taking care of you all month, every month of the year. So if I want to affect obesity in someone, it may not be me, it may be a coach with a phenomenal, blah, 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 cheerleader personality that gives you a call and says, Tom, I'm seeing here on our dashboard that you gained 3 pounds. You made a commitment last week that you were going to walk 5 miles last week. Your Fitbit or your Apple iWatch says you walked 3. What happened? Well, I sprained my ankle. Okay, understood. So you're 3 miles behind. What are you going to do for me this week? What's your commitment? Well, I'm going to do 7. Okay, all right. We'll touch base next week and see where you're at. That's how we affect changes, because that's how it happens in the business world. That's why these executive coaches are so phenomenal.
I think what you might be hitting on is a sensitive topic in the context of, there has to be, let me back up. We talk about episodic care. We talk about value-based care. A lot of doctors are challenged with how to get to value because they have to take on risk, and then therefore to have a financial model that puts them in jeopardy, right? So I'm an advocate of saying before you get to value, there has to be this continuous care model, and this continuous care model is not. It goes beyond seeing the child at the age of 12, seeing the child at the age of 13, 14, 15, 16, right? Once a year. That doesn't work, right? So how do I provide this continuous care model to encourage the outcomes that you're striving for, right? You getting better exercise, taking your steps, taking that would ultimately help reduce the underlying diagnosis of being obese, right?
Yes.
So, but doctors, are, as you know, are on a hamster wheel in the context of I got 20, 30, 40 patients a day. I can't get off because I have to, without revenue, I can't generate, my practice is not viable anymore, right? So it gets into this constant churn. Point there being is, how do I, as a provider, jump off the wheel and rethink how I'm delivering care? And how do I create this reach into my patient base to get them more engaged in thinking about their wellness on a day-to-day basis?
So I think that one is text messaging, and depending on your population, it's going to be text messaging with video, because the less educated you get, the more illiterate you are. So you still have immigrants in this country that can speak English and can speak Spanish, but they're primarily Spanish speaking, but they can't read either. So I can text them till I'm blue in my face. They don't know what the text says. So it has to be in video so they can hear it and maybe play it again. That's one way of reaching them. We do need to change from being just paid for one physical and being paid for taking care of that person for that year. And there are companies that are already doing this with big employers, and they have tremendous success.
So it gets back to the regulatory side of the equation, right? The regulatory side says you must have a ONC compliant EHR platform, and you must have this, and you must have that, and you must take on risk. But at the end of the day, ask a patient, consumer, if they know anything about value-based care.
They don't care.
And they don't know, right? And the point there being is, I'm a consumer. I can't help you, doctor, get the value because I don't even know what that is. All I know is I want to play this sport and I need an annual physical to do it, right? So therefore,
Yes.
give me my physical. But I had one person on the program. They said, the neighborhood store has 30 some different flavors of beer. They have a lot of sugar candy. They don't have apples and oranges and lettuce, healthy foods. But that's the store I got to go to, and that's where I'm going to buy most of my food. So this is where I think we all need to change our mindset in that to reimagine the delivery of care and to change the true pitch of our financial spend and our outcomes. We as a society need to rethink all of the above in the context of what is healthy for us. Start reading maybe the labels on the back of our food boxes need to be clearer as to the unhealthy things that we eat on a day-to-day basis. Thoughts?
So you're talking about implementation science and change science. The difficulty with diseases like obesity, diabetes, hypertension is that they don't cost you enough pain. Because if I cost you enough pain, you will change. But when it's silent, it just festers and gets worse until you have a massive heart attack or a stroke, and then you want the problem fixed. So that's the gap. I don't think reading labels at the supermarket and having vegetables and all this makes that much of a difference because the person's not feeling the pain. I've seen plenty of patients, my cousins included, after a heart attack. Now they eat well and they walk an hour every day because they don't want to die and they want to be in the cardiac ICU again. But before that, they could care less.
Yeah, you don't know much about me, but my father, as many people in this that are listening to this program know, did have diabetes, and he was obese. And you're absolutely correct. It doesn't hurt. But the last 5 years, he had two separate amputations of his legs, one at a time, an amputation of the arm, amputation of the finger on the other arm, the other hand. We watched the dining room get converted into a bedroom. There's just a lot of, so those last 5 years, there was a lot of pain across the board. And that's where, that's where all the money is spent, right? But with all due respect, we want to keep them
Yes.
as stable as possible. They're doing dialysis at home and, lifting still a heavy individual out of bed into the wheelchair. It can be quite taxing. I always said it was good that my mother had 6 kids because she had a lot of extra caregivers to help in that scenario. So, but the point there being is we just don't look at the end, if you will, in the context of when I eat that sugar candy. It's not a once and done deal, and I think that's what I was advocating in the context of we need to change the way we think and behave.
I think you're absolutely correct. If we could change behavior, we could have a big impact. I do think that the behavior is going to have to be changed by a lower level license than a physician, or maybe perhaps not. But most physicians today can't see 25 patients in the office and coach another 5 or 10 on the phone, on a webinar, on Zoom, or whatever. There's just not the bandwidth.
To your point, a wellness coach is an example. Someone that's going to reach out and be, I might even couch it as a social media coach, right? Someone that's reaching out, reaching the patients where they are, educating them. I think that's, you nailed it in the context of what we need to do is re-educate our consumers, our patients, again, how to maintain wellness over time, and that, while you might equate that to, I can give you a vaccination today, which would eliminate a lot of things tomorrow. Education today could eliminate a lot of things tomorrow, right? Thoughts on that?
Absolutely. That's where I think there is great opportunity, where you can marry the concepts of execution, lead and lag indicators, measure data like that's not disputable. Your blood pressure is your blood pressure, your weight's your weight. Whatever Apple device you have or Fitbit will tell me how many steps you took today, and I can tell from that whether you're going to keep gaining weight or not. Now I just need a human who's very optimistic, and that's not your regular physician. We're worried about risk, who's going to die, who's going to have a bad outcome. None of that teaches your brain to be optimistic. Well, a coach is very optimistic and a cheerleader and says, okay, well, you didn't do the steps you're supposed to do. You gained 2 pounds. Let's think this through. Let's try better for this week. And I think when you merge those two and you pay for that, you will start changing it, but you won't see it for decades.
Well, that we would agree. There's this short-term initiative, right, that we need to engage, but at the same time, there's this longer-term play that we need to implement to mitigate the repeat. Yes. and our own health system being on this hamster wheel of, okay, you've got new 65-year-olds coming in, right? Let's go through the same circle. So you have the last word, doctor. Any thoughts in closing?
Well, first of all, thank you for having me. Really enjoy having a conversation with you again. I think we need to go back to basics. The fundamental magic of medicine is a conversation that happens in the exam room between the patient and the doctor, and sometimes a conversation between 2 doctors treating 1 patient. You can't replace that with text, emails, EHRs, quality improvement measures. It's not replaceable. Second of all, we need to be more aware of what we're doing to our own selves and how that impacts our own health, which is a mind shift. And but I'm very optimistic. Some technology solutions are going to change where we are right now. And you come from the IT industry, so I think we're at the Walkman stage of evolution. We haven't even really gotten to the iPod, but we will get there, and then we will get to a smartphone that everybody wants to use, and they don't have to spend 2 days in good boy school to learn how to use the system. And I also think that we're a little bit in peril because it feels to me that we're in the wild, wild west of consumer products. And we feels to me that we, through PE and VC, both in the medical practice arena as well as in the direct to consumer, we're probably in the 2000.com situation. A lot of non-viable businesses that don't change anything, don't solve a problem, but because they got X number of eyeballs or they could get 1% of a 3 trillion market, people are throwing money at them. And some of them are dangerous. Like the recent Wall Street Journal article of the online Adderall pill mill, where they were just prescribing Adderall, Xanax, Ativan to everybody online through telehealth until CVS and the Fed shut them down. That's not good care. That's not improving healthcare. That's a waste of money and can be potentially very harmful to our society.
Doctor, great having you on the program. I very much appreciate your candor and your insights relative to how we can go about creating and reimagining a better delivery of care. So until next time, thanks again for being on the program. Have a great day.
You too.
I want to thank the show sponsors, HP. HP Engage Long Lifecycle Products provides the stability, safety, and security you need, plus flexibility and performance designed for today and tomorrow. As well, GenieMD, providing a modular, scalable, and customizable virtual care platform and clinical services to help providers extend care into the home, increasing access and quality while driving new revenue opportunities. If you missed part of today's episode, you can tune in at the same time, 11 a.m. or 7 p.m. Eastern, throughout the week, and be sure to check out the program page on healthcarenowradio.com. And remember, connect or follow me on LinkedIn, Twitter at FoleyTom, and follow the show's hashtag, The Virtual Shift. I'm Tom Foley. Until the next shift.